So I've been asked to do a recording of an osce case, which I don't know what it is. So as an example of how to present for an osce student, as a student presenting for an osce examination. I'm Gavin Lyman. I'm going to do this as unsighted. I don't know what the case is going to be. The guys have set it for me. Anthony's going to be my patient. I make out of my fourth year medical student. First, before we start, most important, obviously always acknowledge that we're on traditional Kaurna land and the Indigenous land we're on. Acknowledge the elders both past, present and future and emerging, and recognise how important the land and culture is for the Indigenous people. We also like to say, before you assess any patient osce, it's quite good, and this will be quite important, it's quite important to be aware of bare above the elbows. So when you're getting dressed for the osce, it probably won't make a big difference because people understand if it's got a bit of time, but really in a hospital situation, it should be bare above the elbows and no rings or jewelry on your hands when you can. And that should be the case in a hospital scenario most of the times. All right, and I'll try and do that and roll my sleeves up. Also, more importantly too, is not more important, but also part of that is to make sure you have alcohol in your hands when you walk in. All right, so the guys are going to give me a 2-minute reading time for an osce case, and I hope I do okay. I hope I pass, and we'll see how we go. I hope this thing's recording. Let's check it's recording. Looks like it is. Yeah. Yeah. Due to that recording. Okay, so here's going to time you for the 2-minute reading time.
How about, okay, you got a new time and I'll follow the instructions.
No, I can get the whole thing. No requires that any further history. So it's Richard, from scenes fallen after skateboarding 10 days earlier. And we've been asked to basically, the advice and information we've given us is it's 10 days of pain, put ice on it, it's still sore, no past medical injury, no regular medication, do a hand examination, and summarise the findings and differential diagnosis. Is that right? How am I going for time?
Got 1 minute and 20 seconds left. I'll go straight ahead to the 8 minutes.
Right, no, that's all. I've got to think about it. So in my head, I'm thinking, first of all, the hardest part here is we're going to pronounce Richard's surname. It's actually a hyphenated name, which probably miss up halfway through, so I'll make most of it. So not to upset him, I'll just call him Richard. So left hand pain after 4 weeks, 20 years of age. Fall on that stretched left hand. The most common scenarios would be a traumatic scenario, a fracture. You could get a dislocation of one of the joints, or it could be initial presentation of infection. But still, it could be a traumatic presentation of that scenario, would be less likely. So if I'm doing a focus examination, I might do a screening neurology examination, but I'm not going to focus too much on that. And as it is a closed injury, which I said it was, it's been unlikely to be a tendon rupture associated with a 20-year-old guy, so probably won't focus as much on that. And we're going for time.
20 seconds left.
All right, Mike Kane.
Yeah.
Hi, I'm Gavin. I'm a fourth year medical student. I've been asked to look at your hand. I've been told that there's no further history to obtain. I understand 10 days earlier you fell and injured your legs. That's right, after skateboarding, and you're sore. I didn't need to find out that where you are actually sore. Can you show me where you're sore?
It's kind of around here, this sort of area.
You're pointing to the thenar remnants, the base of the thenar remnants on the right side, the radial side of the pain. And it only started after that traumatic episode, wasn't it?
That's right.
Okay. And have you had any associated affections with any fevers or feeling of any nerve, or any numbness or pins and needles in your hands or anything that worries me?
None of those.
That's just localised pain. All right. And is it there all the time?
Pretty much, sometimes both of them.
And if you, apart from putting lights on, you've had no other treatment at all?
Maybe just some Panadol, but it's not that much.
Okay. All right. I don't think it's a lot more. You're otherwise fit and healthy, no major medical problems or anything at all?
That's right.
All right, so you need to put your phone down for me, and we're going to examine. I actually prefer to step to standing up, but I will keep looking like that, okay? So that's what gives you your hands. I'm looking for scars, any weight thing, any bruising settled quite quickly.
There's nothing that you can see on the hands.
There's nothing there. I'll that's all right. Still got 8 minutes, I'll focus on it. All right. Do you have any numbness in your hands at all or anything?
Not that I've noticed.
Okay. I'll touch on this quickly to the screening neurological examination. No numbness in these fingers. Thumb, index finger, median nerve distribution, the little finger on the nerve distribution, no numbness in this area. Yeah, haven't lost any movement at all.
Not that I've noticed anything.
I'm going to palpate the area now, if that's okay. I'm going to turn you, which is the sore hand? Left hand, is that correct? That's it. So let's put the right one. I'm going to focus on the right one. I'm focus on the left one. I'm going to leave the right one go at this stage. And if there's no pain in the right one.
No, it's all good.
Okay, I'm going to start with the radial starwood. Sore there, everyone?
No, it's okay.
What about in the snap box here? This is
Very
That's pretty
pretty
big.
sore.
Yeah, that's quite big.
What about the base of the metacarp? Is that okay?
Yes, that's okay.
You're going to turn your hand over to trapezing or trapezoid.
Okay then.
Okay? Turn your hand over here. It's going to go to the tubercle. It's okay. Distal radial ulnar joint is okay. The ulnar side of your hand is okay. It's doing a screening of these areas. It's not painful in any of these areas. But okay, and your fingers are okay as well.
Yes.
Hand over here again. No other pain anywhere else in the hands. It's purely in the snuff box area. Is it painful here? Did you start as painful?
A little bit as I get rid it.
Okay, so looking, this is going to, we've palpated the area. I'm going to get some motion going now. Straighten your fingers all the way out for me. Make a fist.
There's significant pain on adduction and flexion and extension
Of the
in the left thumb.
Adduction, flexion, extension. Okay. Significant pain in this area here. Okay. All right. Can you pull the thumb up and bring the thumb up for me?
Trying my best. Yeah.
Okay. All right. And there's no cuts on this hand, you said. I've bent the tip of the finger. So the EPL is working. I can see the adductor pollicis longus and the extensor pollicis brevis. Bring them right up for me. They are working. You're not sitting, you're mainly still on the start.
Yeah, that's
Turn your hand over here. Sorry, I didn't mean to cause
No,
that.
that's okay.
Please. It's all right. It's sore again. It was a bit discomfort there. Sorry about that.
that's
Can you bring the tip of the thumb down for me? That's okay. And if you bring your thumb out the side, is that sore as well? Most of your thumb is that sore?
it is.
So I don't really want to do too much more, okay, because you're obviously in discomfort. And you likely tend to run that snuff box and also the base of the thumb region. You have problems with motion. We've done an inspection, we've done a palpation, and some motion. You've said there's no numbness in the hand, and I'm thinking to try and test muscle power if they're too sore without doing investigations first. So after traumatic injury 10 days ago, I'd like some x-rays of your hand. Do you have any x-rays at all?
No, X-rays, no.
Normally I want some x-rays. The differential diagnosis in this scenario, obviously we always worry about the snuff box and we think about scaphoid aperture. But anything along that more radial side of the hand can be damaged. Radial styloid, the scaphoid, base of metacarpal, such as Dennis or Orlando's fracture. And also you can get a dislocation of the distal of the scaphoid ligament to the There's more pain distally here. To assess that, I normally want an x-ray before I do specialist test like says, rather test like have to assess that. It's too sore to assess at this stage. So an x-ray of the first line investigation, if that was normal, then I might come back and reassess you and re-examine you to look for a scapular injury. And it'd be very unlikely for a tendon rupture at 22 years of age, unless you've been using steroids or anything, bodybuilding or anything at all, but it's still pretty unusual even at that age. So I'd start off with an x-ray. That would be my answer. So I'd be concerned about scaphoid fracture. It could be a base of metacarpal fingers.
2 minutes is fair.
Beautiful. I don't have anything further. I would add stay in the interim if I use initial management apart being an X-ray. But I would put you in as a back slab or a removable spread, a phrase to protect your hand in the meantime until you go to advice about if there's any concern with making it faster, just in case there's something serious we need to take to the theatre for, and I may need to seek further advice from a big surgeon for identifying it. And there's if you get any other symptoms, may further investigate that. Fever, for instance, I will worry about this being incidental, the trauma being a sign that something else is unmasked, it's an infection, but they're extremely unlikely. It sounds like a straightforward traumatic injury or extraction or dislocation of the scenario. If I think if it is analgesia, I would recommend to take some Panadol or some Nurofen. I wouldn't recommend anything stronger than initially. I think the back slab or split would give you some discomfort. But you should elevate your hand and probably rest and take things quietly. Resting in immunity is your friend to help recover from anything we need to do. So taking a bit of the while side, not going back straight back to skateboarding at this stage. We need to hold on that until we know what's going on. Unfortunately, it might be also going to be a few months until we get into it. I don't know, particularly the centre of fracture. If there is X-ray is normal, in 10 days you expect it was a straightforward fracture, you expect it to show up. On the X-ray, if it's abnormal, then if it's normal, then we may further investigate it either with an MRI or CT. But I'll do this after the X-ray first. Let's do it.
I can see.
All right, I've got to sit here, and during this time, I'm not allowed to speak to the examiner's not allowed to speak to me because they may look me off my next case. So we're sitting here, look at each other for 20 seconds until the last few seconds. But usually someone thinks there's something else to say, and then they go. That's a bit rest, ice, compression, elevation in the short term. 7 seconds ago, you stopped there. What was the scenario you were painting the picture of?
It was a significant fracture, that's correct.
Straightforward scaphoid fracture.
Yeah.
Okay. All right. I'll do that. I think the thing was going to be an extra tricky one.
Reasonably difficult.
The trick is with any OSCE scenario is it's just, if you go to the clinics, it should be exactly the same as what happens in the clinic. Yeah. That's what an OSCE case should be like. It shouldn't be, it'd be extremely unlikely to have a person who presents with a painful hip and a short leg having just returned from overseas and are concerned about missed DDH of 60 minutes and tuberculosis. That's a sort of case that is presented in rounds or discussed with your colleagues and then bring them back. That's what medicine's all about. It should be straightforward cases.
Scenario case.
Yeah, it's inappropriate to have when you get through, what we're teaching in the University of Adelaide is to actually teach you common sense approaches. Now, but it's also at the level which registrars are being taught as well. The only difference between registrars is they have to do all the different grading systems and they have to be aware of those really weird diagnoses. Like I mentioned previously to Alex today, we have my fellowship exam, we get some unusual cases, but that's the difference. You'll be really aware of those tricky things, but generally common things are very common. It'd be safe not to be aware of those common things. Do you want to do another case?